Okay, good evening, everybody. I'm Hussein Hayee. I'm an endoscopist and gastroenterologist from King's College Hospital in London. It's my great pleasure to welcome you on behalf of my co-chair and our kind sponsors, PENTAX, to this symposium on empowering education. For those of you attending the conference, it probably wouldn't have escaped your notice just how high on the agenda these topics are for ESGE, both education and diversity. So for PENTAX to create this agenda at this time shows that they've really taken the lead, actually, on education. And I think many of you who've worked with PENTAX and know that they have really pushed their influence on empowering education and promoting diversity throughout their reach. So I really think to have an agenda like this at this time just shows that PENTAX as a company, you guys get it. So it's a real pleasure to work with you, and I just want to extend my personal note of thanks to the team. I think this is going to be a wonderful symposium. We have some great speakers for you. So without further delay, I'm going to hand over to my co-chair to introduce herself and the agenda for this evening.
Thank you so much. My name is Kasia Pawlak from Poland. Currently at the ESGE, I'm I-chair, so I'm leading the Young Endoscopist group, but also I have an unspeakable pleasure to work with guys from PENTAX, and thank you so much for doing this, because what I've noticed since some time, PENTAX changed a lot, really, and I'm strongly impressed by your work and what you're doing, and how much you're empowering the training and education, and I can wait to see further directions. And also we have here today three amazing speakers. We have Professor Nada El-Domiaty from Cairo, Egypt. We have Professor David Tate from Ghent, Belgium, and we have Professor Amyn Haji from London, United Kingdom. And they will bring us a lot about education and further other directions in diversity in education. So it's my pleasure to invite the first speaker, Professor Nada El-Domiaty, to talk about driving diversity and inclusion in education and talking about her journey.
Thank you. Okay, perfect. Good evening. Thank you, my dear chairpersons, and hi to all my colleagues and friends here in this room. It's really my pleasure to be here today in such an important session, and I would like to thank PENTAX for taking care of this important issue now regarding the empowering education and innovation in endoscopy. This is now the era that we need all to discuss. As Kasia has introduced me, so there is no need to do this. I will talk today about driving diversity and inclusion in education. This is my topic, and this is the agenda. So let's all admit now that DEI, or diversity, equity, and inclusion, it's a very important concept that should be applied to ensure that we have education environment which is diverse and inclusive, that ensure equal access to everyone for all the opportunities, regardless their backgrounds, their various perspectives, so they can learn, succeed, and then innovate. So this is an important issue. And we have also to recognize that these concepts are not just theoretical concepts, and they are already translated to the real life application. And here we have a very concrete example, an important example to DEI in action, which is the effort to empower women in GI endoscopy. And that's why I'm talking about this issue today. Before going for more details, we have to know the current situation or the current landscape for women in GI endoscopy. According to the American Society of GI Endoscopy, in 2023, their statistics, they showed that we have among the gastroenterologists, we have only 25% females in gastroenterologists. Despite that this number is increasing during the last decade, as the fraction of the female graduate is positively associated with an increase in the female faculty presentation. Despite this, we still have 15% only are proceeding advanced endoscopy. Definitely, this is a huge gap. This is a huge gap and significant disparity that should be addressed. And this is what we will try to do now by knowing the current challenges. I think the current challenges for women in endoscopy is quite clear for everyone, and worldwide, I have friends from everywhere. We are sharing the same challenges, either underrepresentation, some work-life balance issues, physical demands, less opportunity for the mentorship programs, less opportunity for training programs, gender bias, definitely, stereotypes. And I will go very quickly through the challenges that I'm facing, or my colleagues are facing, especially in Egypt, because I'm working in Egypt. So the first is gender bias and the stereotype. And definitely women in GI endoscopy encounter unconscious bias or stereotypical views regarding their ability. And it's quite clear and manifested in the referrals, the career advancement opportunities, and some patients may prefer to have male endoscopists because they think that they have more experience and they are competent. This is the second challenge, which is the underrepresentation. And I think this picture is quite clear. This is my team where I'm working in Helwan University. And you can see that I'm the only female doctor, and I have only 2 female nurses. So I'm trying to survive, and this is clearly shown here. The third issue, the patient perception and preferences. As we say that some female endoscopists encounter patient bias, where the patient prefer, for sure, male physician. And sorry for the male doctors here. We are not against it, just we're trying to highlight the problem or the issue that we are facing. Conversely, also, some patients may specifically request female providers for gender-sensitive issues, increasing the workload for the women in this field. A lot of publications have discussed this issue. So our current situation in Egypt is that we have a high demand for a well-trained female endoscopist, especially in the rural areas where the national screening programs for colorectal cancer are developing and extending, and we still have a significant deficit in these numbers. When Egypt now, we have 120 million population, about 50% are females, 58% of them are living in rural areas, so definitely there is a need for gender diverse representation in endoscopy, and this is a crucial, important issue for us. To navigate these challenges and create more equitable future, a lot of principles or concepts that we're trying to work on it everywhere, increasing the representation of women to have more leadership positions, trying to change the policies, to have more supportive policies for providing flexible work time, zero-tolerance policies, ensure equal access to the leadership and promotion rules, and ensure also that the room ergonomics are fit for everyone, either male or female endoscopist. Try to increase their opportunities to be the PI of different clinical researches. And finally, have more supportive initiative, enhance the mentorship programs, leadership training programs, and increase the network of the female endoscopists, have more sponsorship programs as well. These principles have been mentioned clearly and perfectly in the last position statement that published last year by the European Society from the DEI committee, where they mentioned 12 principles that should be followed to ensure that we are applying these concepts in our work atmosphere. We have a lot of supportive initiatives everywhere, but still we have more and more. And here, during the last 2 minutes, I will go very quickly about our success story in Egypt. And we have created our first initiative for supporting women in Egypt and the Middle East. It's empowering women in GI endoscopy. It's called ESGE program. We have been working together, me with my team and friends, that I'm so happy that we created this together and working for 2 years. I'm having Shayma Afifi, the head of the scientific committee. I'm happy that she is here with me today. She is a partner in success with Shakir Wagih, also the head of the organization committee, with a wonderful 10 female endoscopists eminent in Egypt in this field. And we have been working to create this program. And we had the launching event in September last year. It was a successful event with like 300 participants from doctors, with 200 participants from nurses, with the support of our mentors, either international mentors or the national ones represented the different universities and hospitals in Egypt. Through 2 days, wonderful 2 days, we have a scientific presentation as well as hands-on training. And here really, I would like to thank PENTAX. They are also partner in success. Since I started to do this initiative in Egypt, they support the idea from the first day, still supporting, so thank you for your support. And this is also the session for nurses training. It was a hands-on training for the nurses to know very well the anatomy of the endoscopy. And then we will surprise with the feedback that we received from the social media that make us more motivated to work more on this initiative. Trying to create now and establish our ESGE school for the juniors, working on the basics based on the surveys that we did in the rural areas in Egypt, that the doctors still need to know more about the basics in the colonoscopy, the upper and the EUS as well. Beside the digital education, I think that David, I will not go deep in this because he will give us a perfect lecture about the digital education, but we already established our YouTube channel, and we have our organized already for this year the webinars and different podcasts. So the take-home message that I want to deliver, that the challenges facing women in GI endoscopy are demonstrated with a clear data. And empowering women in GI endoscopy is a concrete concept for DEI in action. There is a growing recognition that diversity enhances patient care and broaden perspectives, definitely. For those of us here believe in the advancement of the women, there is no need to wait for the global policies to change. Start with your unit and develop the process by which the transformation will achieve. And this is what we are trying to do, especially in my unit, where I'm the only female doctor. Thank you so much. This is a QR for our initiative, and I would like to invite you all for our second annual meeting. It will be in September the 11th and 12th this year. Thank you so much. So if I still have a time, I have like a video of 2 minutes for the event. I would like to share it with you. This is a success story for us, at least. Thank you so much. Thank you. Any questions?
Thank you very much. That was really, really amazing, and it's great to see that you could provide such initiative. And I know that, unfortunately, this is what you're presenting. It's I feel in entire Europe, because we're struggling with training in general. So we have different discrepancies related with countries and with training organization in different countries. But thanks to these initiatives and also this is what PENTAX is providing, we have much, much more opportunities to be trained by ourselves, like on our own way, right? Because we have to seek for all those opportunities. So do you have any questions to Nada regarding the training?
Perfect.
Perfect. So we can go.
Thank you.
We can invite another speaker.
So it's a great pleasure to invite our next speaker, David Tate from Ghent in Belgium. David and I have something in common, actually, which we're both acolytes of the great John Anderson, who's in the audience looking at his phone. Welcome, John. David has taken that forward, though, that sort of enthusiasm for education and developing the digital platform Geeks, which many of you will know. If you don't, then I highly recommend you sign up and take a deep dive into endoscopic education on a digital platform that is really, really high quality. Thank you so much, David, for coming and agreeing to talk to us. I can't think of anyone better to give this talk.
Wow, thank you very much for that extremely kind introduction. I am also feel very privileged to stand here and talk about training. I echo what everybody so far said, that training, that we have a problem with training. We certainly need to be better at it. And so I want to just give you a little discussion. I'm also very happy to see some of the South African crew here, with whom we've also been, via the support of companies like PENTAX, interacting with and using this platform to bridge the global divide which might exist in training. So briefly, and this is not just about Geeks, this is not just, I'm also doing ESGE Academy, because I truly believe that whatever method that we use to get training out there is fantastic, and we need to use it, is how can we leverage some of the tools that are coming online. There are so many things coming online now. I mean, artificial intelligence, the huge potential of generative AI. We have a huge amount of multimedia capabilities and the way that we can capture them in endoscopy. We can discuss live with people on the other side of the world in our endoscopy unit. So how can we leverage all that for training? Because a lot of that is leveraged for, very nice symposia. Everything's very nice. We're doing a nice technique, which all of us likes to do, because that's where our happy place is. But what about training, and how can we leverage it for training? So the standard model of endoscopic practice and endoscopic training, I think, is that I go to a workshop, I do some hands-on with someone who knows what they're talking about, and I get some experience, and I come back, and that's all very nice. But of course, if I do that, then I have an environmental cost, I have a sustainability problem, potentially I don't have enough money to do that. Many people in lots of different areas of the world don't have financial resources to do that. So there is a problem in the global accessibility and access to training. So we need a broader approach. Hands-on is, of course, necessary. No one says hands-on is not necessary. But there are many things that do not need hands-on exposure to teach them, or to train them, or to learn them, or to experience them. Of course, also, it may be that you go to a physical course where the trainer is not particularly consciously competent, and then you've invested a lot in that course, and you went to not a good course. So it would be nice if you just had a whole plethora of courses out there available to you that you could choose from, and that you could have some expectations, some buy-in to know that that course was actually going to be of good quality. Maybe also it would be very interesting that before you went to that course, that you had some preloading of knowledge, so that when you turn up to that course, you're not having a conversation with the trainer about what the word, for example, let's just talk about polypectomy, diminutive, what does that mean? Maybe you didn't get exposed to polypectomy, maybe you're not a first language speaker of English, and then that sort of conversation is totally gone. Diminutive means small, and then the conversation revolves around the technique, not around the terminology, or not around something which you could have taught on an online platform. So these are the domains of learning. You have technical skills, cognitive skills, and non-technical skills. I would like to convince you that this and this can be taught virtually. and that this is the only thing you need to be in an endoscopy room for. How do pilots do it? Do you expect that your pilot, the first time that they do a flight, is in the cockpit of the plane, piloting it as the captain? Do we accept that a little bit? I mean, let's just have a little honesty check with each other here. Is that something we maybe have experienced in this game? So I think that simulation has to be acknowledged as something positive. We have invested significantly in this, both in the ESGE and in Geeks, to drive forward the way that people engage with virtual learning. I'll come back to that in a little minute. So I do believe that all of that maybe amounts to quite a lot that you can train virtually, and that you can say that hands-on is not completely the be-all and the end-all when we're talking about training. Before the procedure, during the procedure, after the procedure, all of this can be helpful for virtual education. How does it work before the procedure? Well, of course, before the procedure, a lot of the discussion with the patient, a lot of the decision-making before you do, for example, polypectomy, that does not require you to be in an endoscopy unit to learn it. During the procedure, one critical concept is that trainees who come to us, and I look at John and I think about myself pre and post when I did a fellowship, for example, the cognitive load of being trained to do a practical skill is dramatically less if you understand the terminology, if you understand what the trainer is trying to get across, if you understand what the equipment does, if you understand how the generator works, if you understand what the settings should be. So it's critically important that trainees come with some form of knowledge before they do, and that you can get from virtual education. And after the procedure, interpreting the procedure report, interpreting the pathology specimen if you're doing ESD, for example, is critically important and can be learned virtually. This is an interesting graphic I stole from Roland Valori, another one of my mentors, who, and it shows that probably when we're talking about polypectomy, that people, and lesion detection, that, you know, people, we train people to get insertion, right? And then we kind of stop. But actually, all these other things, which are maybe, certainly in the UK, potentially better trained, but in other countries, it's kind of a little bit the Wild West where I've worked. These things can be trained virtually in quite a lot of their aspects. So maybe we can shift the curve in this regard with lesion detection and polypectomy. How are we doing that? What novel things are we doing in Geeks and ESGE to promote this? Well, we are using whiteboard. We are using graphics. We are capturing the procedure as we're doing the training. So, for example, you have John Anderson potentially in Cheltenham. You have me in Ghent. There is a person being trained by John Anderson in Cheltenham in Ghent. And that person then has a video feedback from images taken during the training on John Anderson's iPad in Cheltenham, streamed to Ghent, and they're in a seminar room in Ghent, having post-procedure feedback, immediate post-procedure feedback, but not just, oh, you know, you didn't do this very well and you didn't do that, but on the video, at this minute and this second, you did this, watch it, and then watch what you did, and maybe you could have done X, Y, and Z better, and then some whiteboard graphics to really hammer home the improvement. And that has just been, for us, I think I speak for all of us, a transformation in the way that we are able to communicate with our trainees. So video feedback, optical diagnosis, loops, all of it can be communicated in that way. And then there's, of course, non-technical skills, which actually we haven't really invested so much in. ESG has quite a lot on that, and I think that this is also something that can be talked about, can be looked at on an online platform, how to do it, but also when you watch yourself, being trained, or when you watch yourself training. And I do remember a great moment in one of our symposia, and Roland's sitting there, so he won't mind, when we had a video, and I thought, I've made a fantastic video of myself training. I was so proud of it. And I gave it to him to use in one of the symposium sessions, and I wasn't present. And then I watched back what they said about me training, and I thought, my God, I really shouldn't have submitted that. But so all of this non-technical stuff, because what was I doing? I was standing on the wrong side. I wasn't looking at the patient, the doctor's hands. I had missed all these visual clues, but you could pick those up from the video analysis. So I think training as well can be properly assessed and done virtual. something really important that we're really into, ESGE is now into, Geeks is now into, is image interpretation. Like, why should we be waiting? Why should I have to go to Amyn's unit and spend 3 years seeing all the invasive lesions that he does when I can watch them all online? And then I can go to his unit and I can actually focus on the resection technique and use that for decision making. So this is entirely unnecessary, and we really have invested in that. Both the platforms have invested in that, and I think that really, if you're not doing that in your practice, you must engage with virtual to go and look, because we're then having lesion, endoscopic image, video, matched histopathology. This is the way to learn. This is the way the Japanese do it. They sit in a room, they sit there with photos, pathology, 200 examples. That's how you learn how to interpret a lesion. Very quickly, 2 or 3 other studies that we've done. So you might say, well, you're standing here and you're saying all these things. Where's the evidence? Well, we have some evidence. So this is a nice study. Peter Yan is sitting right there behind Lynn in the front row. He did this study of the impact of a 1.5-hour Geeks course on image interpretation. And you can see that pre and post, blue pre, red post, that there was an improvement across the board, both in experts and non-experts, actually, that attended. And I'm talking about people who are not experts in endoscopic imaging, but people who were at different experience levels, with a 90-minute intervention 1.5 months later. This one, back in COVID, you can see the great masks, where this is something Lynn did sitting here in the front, where we looked at colonoscopy KPIs, pre and post a learning intervention that we did virtually. And across the board, they improved without statistical significance. And finally, the final thing I really want to say is, if you give people a structure, and this is something else that we've really invested in, if you give people a structure, you keep on hammering the same structure, and they can watch all of the material on your platform or in the space in the same structure. This is an extremely powerful way to educate, and therefore an extremely powerful way to get the message across, for example, in this case, about image interpretation. A final thing I would like to say, one more final thing, is about simulation and tip control. And so our final delve into what you can achieve with low budget and what you can achieve in training is that tip control is a kind of global message in endoscopy training. So we will all know, we walk into a room and we see high quality or low quality tip control. We've started to quantify it, and we've made a model to do so. I think the rest of this, which is about competency assessment tools and which is about mentorship and remote coaching, I've already really covered. So my conclusion is, if you have 10 minutes a day, look at a polyp image, reflect on a case, follow one micro-learning module, watch one short video on Geeks. If you have 1 hour, join a webinar of ours, join a webinar of ESG's, follow a learning module, discuss your cases online, watch a procedural video. If you don't have any money, there's our YouTube channel, there's ESG's YouTube channel, there's Geeks free videos, there's ESGE free content. Build your own personal curriculum and really try to, in the end of the day, set yourself goals and set yourself a timeline for your own learning. I think the combination, my final slide, of hands-on experience and theoretical training, including virtual, can really make a complete endoscopist, and I commend these platforms to you, and I would encourage you to spend time investigating. Thank you very much for your kind attention.
Any questions for David? Yep.
Yeah. Hello, I'm Dr. Leonardo Sosa from Strasbourg, and I've been doing many courses with PENTAX, of course. We've trained more than 400 doctors already in U.S. therapeutics. So my question, I really admire your presentation. What do you think about training with live models, like live pigs, right? I would like to hear your experience, because my course is based on live modified pigs. We publish the course, the pigs, the modification, and we managed to do 170 procedures in 2 days with our team on our ateliers. So I would like your experience about that.
Yeah, I think it's entirely necessary. So for complex stuff, I think that the animal model, I mean, I don't know where it goes in the future. Maybe there are changes that mean that we have robotics and things which can properly simulate this environment. Maybe bleeding comes. Maybe that is a solution to not using the animal. But I think in 2025, there is a key place for this. There is a key place for hands-on training. But it is niche, and the majority of this training, the basic training, can be delivered virtually. This is my view.
Yeah, I agree. In fact, in our institute, we're working all the platforms. We work in virtual, we work in BoxX, we work with
This is the way.
LightPix, and we work also in simulator during the creation of AI also. So yeah, I agree.
Fantastic.
I have a question also, David, because like I feel we are a little bit different generation. We can observe a different generation of upcoming endoscopists and young endoscopists, and we are more keen to do. So learning by doing, but you're trying to convince that self-training, because I can consider that this is a self-training, what we are doing at home, it's a key, and I believe the same way. So how would you convince the young generation that self-training is really a key, and they're also supposed to visit those platforms and just take this? Because it's not easy to force yourself when you're tired after work, you're a fellow, you're doing so many things, and then you have to come back home and then just sit and, you know, learn by yourself.
I'll tell you a story. There was a gentleman who came to me from South Africa, and he had watched probably every single video on one of the platforms that I had here. He came for 6 months. He went like this, completely in his practical skill, because everything I was doing, he said, oh yeah, but I know you're going to do that next, and then you're going to do this, and then you're going to do the other thing. And then he went back to his practice in South Africa, and he has just taken off, and he is probably as good an interventional endoscopist as me, and he's absolutely shortcut the time it took me. It took me way longer than it took him, and maybe that's because I'm not very good. Or maybe it's because he invested in his own personal education. So, of course, you cannot force people. Of course, there are difficulties. Everybody understands it. We had it. Everybody has it. But if you want to invest in your personal education, the best way, before you do a fellowship or before you do a practical course, is to go virtual.
Excellent. Okay, you convinced me.
Thank you.
Thank you so much. I think we don't have any more questions. Oh, we have some questions, please.
Oh, yes.
Sorry, Roland Valori here. Sorry, thanks, David. That was a really great presentation.
Wow. Now I feel good.
So, no, I mean that. So, I think just on the back of that question, that's a really, really important question that you've asked there. And I'm doing a lot of training at the moment, and I'm one of the Geeks founders. And what I say to the trainees, I say, if I've got a list where I'm doing some polypectomy, and there are 8 polyps in the colon, if you come to that procedure with the knowledge required to assess and make the right decisions for those polyps, you can remove all the polyps. But if I have to spend, minutes explaining this and that, you're only going to remove 3 polyps. So I think we've got to find ways of helping the trainees understand that their journey won't just be faster, but they'll just be doing more of what they want to do on the hands-on. And that works for me.
For me as well. Thank you so much. And very last question, please. Or
Just
maybe
to share-
lady. Okay, let's say
an
lady.
experience. We were just recently in an emergency room, actually, and we had to put a stent, a dentist stent in for a varicose bleeding. Nobody had done in our unit before. None of the nurses even seen anything at all. So we played some videos, actually, looking at that 4 times before we did it, actually, and very successfully deployed that. So there is room for learning these things, actually, and I think it's going to be more important for trainees. And I sometimes ask my trainees, first, even when you're starting gastroscopy, go look at all the videos, because my endoscopy nurse is all looking at all of them. They know the 25, 30 conditions. Even if they've not seen it, at least they are aware of it. So I think there's a very important, it should be part of the curriculum, actually, to be honest, that they should be introducing online learnings. And you can learn whenever you like. You don't have to go home and learn it. You have dedicated time these days, allocated time to do things. So I think it's a way forward also. And animation, all this will be coming. As you said, you can predict what is coming next. Thank you.
It's a great point. I get at least 1 email a week that says, I learned a technique by watching your platform. I never did it before. No one in the department did it before. I successfully did it by doing whatever it was, a VESCO, whatever. So I completely agree with that.
And please, the last one.
I don't think it's a question, more of a comment. I'm Didi from South Africa. Just to say, I think congratulations on your platform. It's amazing, and it's, I think, making all of us much better teachers. And I think for me, the biggest success of the platform is standardizing high-quality teaching. Depending on where you're from and who teaches you, you might just be out there making, bigger mistakes with greater confidence. Whereas here you might be aware that your teaching is inadequate and in some places maybe a little dangerous, and you can do something about that without necessarily jumping on a plane and doing an international mentorship program. And it means that our fellows, wherever they're from or wherever they might be, are a Wi-Fi connection away from the experts in multiple fields and really good quality teaching, high quality pictures and videos that are reproducible that they can play at any time. So I think that's been the greatest value from somebody from South Africa.
Thank you so much.
So that couldn't have been a more excellent segue into our final speaker for the evening, actually. So it's a great pleasure to introduce my friend and colleague, Amyn Haji. Many of you will know Amyn. He's a colorectal surgeon by training, but has expanded his portfolio to be, I think it's fair to say, one of Europe's foremost ESD practitioners. He's a very careful endoscopist and has really refined the diagnostic side of therapy at King's, and I've learned a lot from him as well over the years. So it's a great pleasure to welcome Amyn to talk to us about using digital platforms to really train in a complex procedure.
That's great. Thanks very much, Boo. And just to support what David is saying, professional athletes will actually go through this process before they go on and do a particular task, and that's happening in athletics and swimming. So actually going through a process before you do it actually has huge advantages. So I'm really going to focus on the more traditional route, because I think David's spoken a bit about virtual and online learning, and I'm going to really focus a bit on ESD training and what we've done over the years to try and combine some of the standardized ways of approaching lesions and how we teach and how we structure that, because I think having that structure is really important. And of course, look at some of our mentoring techniques that we use within the Forward program. And we know that ESD is challenging, and training in ESD is extremely challenging. We've heard about this, and it's not only about doing the actual technical aspects, but really it's about making sure that you get the appropriate endoscopic diagnosis and the pathological input, and that you can do, as we've just heard, virtually, and have a lot of array of images to support you with that. And in terms of third space endoscopy, there's a lot of things that you can do before you come to do technical skills in the lab or in a particular unit, because all that sort of theoretical knowledge and the technical proficiency you can watch and learn and have that preclinical training that we've just heard. And then you've just got the supervised training that you do either in the lab or in your unit to then reach that independent competence. And of course there is a curriculum, as you know, from the ESGE, and when we were involved in this, it was really to try and come to a common ground. And what was useful was to have a platform that endoscopists could use in their institutions, particularly when they were starting a new procedure, going through a novel procedures committee and having some idea of that they've gone through a curriculum and this is what they've achieved. So that period of training, after you do your theoretical aspects online, you could actually do in the lab, and with animal models. And there were some certain standards that you'd need to reach before you go on to doing initial human cases, which are supervised, and then have a certain competence of a minimum number of cases per year, which we all disagreed on, but we reached a conclusion to say that, okay, this is what you need to do, and to reach that with appropriate audit, having 90%, at least 90% on-block resection rate with minimal complications. So everybody has their own way of doing it, and we do it in a very similar fashion. And one of the issues is how many procedures do we need to do to achieve competence? How do we choose trainees and fellows to actually go onto the program itself? But that initial aspect is all really done with their preclinical knowledge and also their lab training, to then identify those who would go on to do the observation and assisting in procedures, and then going on to have supervised resection of further 10 cases. And there has been some data to show how many sort of cases you potentially might need. And for colorectal ESD, I think most of us would think that we would need about 80 to 100 cases, but really it's meant to be competency-based rather than actual procedural numbers. So some who have done all that preclinical and online learning will have a much shorter time in order to achieve that competence, and it might just be 20 or 30 cases rather than achieving 80 to 100 cases as there. And of course, as you do more training in the lab, we know that simulation work will actually reduce your procedural time and reduce your complications. So it's important to do that. David spoke a little bit about tip control and technical aspects, and I think you can do a lot of this learning without doing ESD, because you can develop certain muscle memory in order to achieve that same goal. Because if you're doing, for example, polypectomy or biopsy or EMR, if you use something, we call something a hand-on scope technique, and that's for training for ESD, so our fellows would do that, is that they would keep the hand on their scope and then advance the instrument, which is either a clip or a biopsy forceps or a snare, with their left hand to always do that same movement. So you then develop that same muscle memory and tip control that you would need for ESD. And all this can be done without actually doing the procedure and using that. One of the aspects is to standardize approaches and then compartmentalize, which trainees would do which aspects. And what we've done really is standardized it in terms of using submucosal tunneling as a standard. And then you've got aspects that we would have either beginners and intermediate trainees that would do different portions of the procedure. And the incision and trim on the anal and oral side is often more difficult than the submucosal tunneling itself. However, the consequences of submucosal tunneling and bleeding would destroy the plane for your mentor to take over. So what we tend to do is ask people to do the initial steps first. So every procedure, incision and trim by the trainees, and then when they get more proficient, they go on to do the submucosal tunneling. And then when they get more proficient, then they can go on to tackle both the lateral aspects, which is either the gravity side, if you can't move the patient, which is more difficult for more advanced trainees, or the anti-gravity side, which will be for more for sort of intermediate trainees itself. And therefore, you can increase what you're doing in a standardized approach for every case where you have trainee involvement in the procedures. I think we're all very obsessed as trainees to do all of the procedure and complete all of the steps, but actually that's not really needed because you can compartmentalize and have different trainees do different aspects of the procedure itself. So standardizing it, and this is just an example of training in that particular aspect on the technical aspects. This is an LSTG nodular mixed type in the rectosigmoid junction. You can see that the fluid in the left lateral position is on the right there, so we know we can't access that area very easily. You flip the patient supine, and then you have the strategy in your notes and also in your report when you're doing the assessments. When it comes to doing the lesion resection, you already know that you're going to start in the supine position. You'll start on the oral side, and you'll do oral mucosal incision and trim. And you know at that stage, then you'll go on to do the anal side, and then you'll go on to the left side, and you'll flip the patient the right lateral to do the final bit. So that planning and that strategy approach is in the report before you actually do the procedure. So the trainees can actually visualize what they're doing before they actually get into the patient and treat the patient. So initial oral side incision and trim, and then subsequently we've got anal side incision and trim through the muscularis mucosae, getting into the submucosal tunnel. And then the next aspect would be, well, you have a more advanced trainee that would do the submucosal tunneling itself, and then we would submucosal tunnel all the way through with an intermediate trainee that would tunnel all the way through to the other side. And then the last aspect really is breaking through onto the oral side. So here now you've got an aspect where you've got the lesion that's been dissected centrally, and then you've got the two lateral components that are left to do after you've done that. And we're still in the supine position, and we know from our planning that we're going to do the left side because we can still access it. So it's mucosal incision followed by trim. That technique is exactly the same as it is for the oral and the anal incision itself. So we will do mucosal incision followed by trim. And then we've developed something that we would say we'd standardize. We do the J maneuver. You start on the inside, you work to the outside. And it's small movements, repetitive movements, keeping that repetitive movements, 3 or 4 cuts, stop, 3 or 4 cuts, stop. And that means that you have developed that muscle memory, and you can do that in a subconscious way to not only increase speed, but also to improve safety for the patients. And then once you've done that on the left side, you repeat the steps in the right lateral position to access the right side. Mucosal incision followed by trim in exactly the same manner. And this might be an area which is actually now, this is anti-gravity, so it may be a bit more easier for an intermediate trainee to do rather than an advanced trainee. And here what we would then do is then you would do the submucosal dissection as what we call with a reverse J maneuver. So you're starting from the inside, working to the outside. Same process, same bits of the muscle memory, keeping that tip control. And you can learn all these tip controls in your regular colonoscopy and your diagnostic procedures, and then just translate that to when you're doing ESD. So really important to develop that same muscle memory each time. And here we're just finishing off to complete this ESD. You've got a lesion which is 75% circumference, 7 by 6 centimeters, and you can achieve this with adequate speed in just over an hour. So with that standardized approach, I think it's something that we can shorten that time. And you may think, oh, well, it's got a very complex lesion, but actually with very complex lesions, it's excellent for training because you've got 4 or 5 different tunnels that you can achieve, and you can achieve submucosal tunneling on the anti-gravity side, which is much easier in one particular area, and the trainees could do one aspect of it, and then you do the other aspect of it on that side. And I think, so we've taken some of these concepts really into what PENTAX have supported into the Forward program. And, this is at its infancy, which is really training initially for ESD. And the first year itself, when we devised the program was really to try and support some of that hands-on training, but also using some virtual mentorship to support some of that e-learning and that sort of online presence as well. So what we initially did is you had 12 trainees in the first year. And this is some of the images during the COVID time. You can see the masks at that time. So there's some aspects of this that were done pre-course, and then it's just some reinforcement with short lectures, but mainly hands-on component when you're actually in the lab itself. And then that's developed over the years, and it's expanded into a program where we've actually now got 15 physicians from Europe, different parts of Europe. And we're really following the curriculum of the ESG training curriculum, and actually you often get 100 applications for this, and we just need to do a lot more. But this is a fantastic program. It's now expanded with much wider faculty members. And that's expanded, as you know, as many of you know here in the audience, not only for ESD, but also for other aspects of training and EUS, and now 17-odd Forward Academy courses, with over 250 doctors that have been trained. And I think in terms of the steps are very similar to what we devised for the ESGE in terms of ex vivo and in vivo training, and then online mentoring with using different tools. We're using both Proximi, which is an online tool to actually have that online mentoring as well, and then also having some mentorship in terms of performing cases in the trainees hospital and have some virtual case mentoring, which I'll talk about. So the digital aspect really was related to support some of the hands-on training that we did. And this was really what we would do is you would support trainees in the program by joining them online and virtually, as David is saying, and then you can actually be with them as a virtual assistant while they're doing their procedures after they've achieved that competence in the lab and after they've done their preclinical training. So we were using really Proximi to do that, and you would either be streaming a live procedure and discussing with your trainees, or you would join a virtual classroom and review some of the videos that they have done and then comment on some of their techniques, or you would actually join them live in a case to support them as a virtual assistant itself. And the massive benefits of all this is that then you have a whole series of videos that you can use and schedule time with your trainees to go through the different aspects itself. So this is just an example. You can see the annotation tool there that I'm just sort of drawing in that area, saying to the trainees, well, look, that's the approach you need to take. It's got a scarred lesion. Let's be cutting from the inside to the outside, draw on the screen, support them as a virtual mentor itself. And then also, comment on their pathological and their margins and say, well, actually, look, that area there is actually quite good. But the reason why you were very close on that left-hand side is if you go back to your video footage, you realize that actually when you were cutting from inside to outside, there was a lot of diathermy, a lot of coagulation used, and therefore you get shrinking of that area very close to the lesion. And perhaps next time they need to be a bit cautious with a wider margin itself. So what have we done at King's as well, I think, moving forward? I mean, this development of sort of King's TV, where you sort of sign in and log into virtually into our endoscopy rooms. And that can be done with any of the platforms, to be honest with you. We have used Proximi within the Forward program. We're also using CHIP, and I know Boo's been involved with the London Academy as well, using CHIP. We're doing some virtual mentoring itself. And I think going forward, particularly using sort of some of the mentoring aspects and video-based assessment tools that there are through the CHIP platform, this would be an excellent platform to review some of the endoscopic videos. So what's been proposed, certainly what you can do with these platforms itself, is that you can actually have the videos been uploaded to the system, and then you can have an assessment tool and feedback that can be created by the mentor to the trainees itself, which can be done either real time or it can be done scheduled at a different time with the trainees in the evening or at the weekend. And then you have a particular video-based assessment tools, and this is certainly something that's been used in surgery, and I think we are going to start using this in endoscopy, where you can actually go on to have different stages of a procedure, particularly for ESD, and those steps that I showed would be within this assessment tool to then provide feedback to trainees that they've reached competence in this particular area, so then they move on to the next stage and do the more advanced techniques. So I think in summary, I think we've got to get the basics right. And I think all those basics we can do virtually. And we can do that, we can understand the indications, we can get the diagnosis, we can spend time looking at images and videos. And then there has to be some element of hands-on. But when you are doing hands-on, we just need to maximize our time because these courses are quite precious. And when you spend 2 or 3 days away from your hospital on these courses, we need to ensure that you're well prepared in advance. So ensuring that you do the basics right during diagnostic colonoscopy, getting your tip control right, and then going on to one of these courses and following the ESGE curriculum. And of course, if you're lucky enough to go on to an advanced fellowship program, that would be great. But that ongoing mentorship can be done virtually. So we can do this virtually at the same time and support your trainees. And I think that's something that's going to be more important, particularly as we're training across the world rather than just training locally in our hospitals. So if you want to learn more, a bit of advertisement, I'm sorry, Chair people, that advertisement regarding King's, please join us in November. And you can see some of these tools in place, and there's a hands-on element as well, which is from the 12th to the 14th of November. And if many of you come to King's, we live in the basement of this building in endoscopy, so you're most welcome there anytime. Thank you very much.
Open the floor for questions for Amyn. David, thank you.
Thanks, that's fantastic and really complementary to what we presented on the basic side, so a fantastic talk, thank you very much. I wonder about the funding. I'm watching you and you say mentor on the weekend, after hours, and I'm thinking, where is the funding for that going to come from? And I'm thinking, thank you so much to PENTAX for what you put into this, but of course the funding for that should definitely not just be coming from industry. So how can we encourage people to, a bit like Kasia said before, like prioritize a bit this and think that this is actually super important and it should be part of, for example, someone like your job plan. I don't know.
Yeah, I think that's the ideal, is putting this in people's job plans. I think the job planning currently in the UK is a real challenge because people are not job planned to do medical student and undergraduate education. So postgraduate education is often given a wide berth, to be honest with you. But I think this is where some of the education charities would support, and certainly we as a foundation are supporting a lot of this work, particularly on the mentorship side, because it is such an important tool, isn't it? It's such an important tool, and we can't just keep going to industry to ask for more support to develop this. So I think a lot of the time, actually, many of the mentors that we have, they're so dedicated to training that they often just do it for free, but it's not sustainable.
Thank you for the very elegant presentation. It's a very interesting project, and I would like to ask you about if there is any ideas about getting this internationally, because this can also be used in international fellowships, and it can change the position now. Instead of people traveling to mentors to learn at their place, they can learn in their place. So do you have any ideas for international collaboration?
I think it's really, the international collaboration is usually support for people that have already trained within a unit or within the unit from one of the faculty members. So often what we would do is we support our trainees, and we've got trainees, we've got 2 in Australia, who've gone on to have consultant jobs, we have 1 in the US, 2 in the US, we have some in Europe who are going on. So we would then support those trainees when they're starting their programs. It's sometimes very difficult and really challenging to offer virtual mentorship with somebody that you've never met. So I think it's important to have a relationship with one of the trainers, and then we could support as part of the foundation with a virtual mentorship for people even internationally. Yeah, I don't think it needs to extend to someone in locally. This is an international project.
As you said, I think it can be done with collaboration with the team already and the trainer teams also, because we need international experts. We still need them in Africa and in Egypt, for example. So if I can also have an international expert virtually with me while performing ESD in Egypt, that would be, a great advance for education.
Yeah, watch the space. We're producing sort of an Uber-style app for mentoring, and being all seriousness to try and support exactly this for trainees, where the actual access is free to the trainee, and it's grants that would support the mentorship. So you could request in the future someone to join you virtually.
Thank you so much.
That would be amazing. Thanks, Amyn. Chairman's remarks, just a privilege to close the session. When I was a medical student, I had a textbook series called 10 Teachers. 10 teachers in gynecology, 10 teachers in cardiac surgery, etc. With the idea being that you're exposed to 10 different ways or 10 different opinions about the same thing. And I think the power of digital is that we can do that. As a gastroenterology trainee, it would take me 6 years to rotate, and I would say, yep, I'd take that from that mentor, and collect things over years. But with digital, as David so elegantly demonstrated, you can do that in days if you do it properly. And so that's my only note of caution for online, is if you're going to go online, do it on a platform that has been well curated and developed with care and enthusiasm. And I hope the speakers today have shown you that their dedication to the task is paramount. I think we can bring the session to a close. Thank you for a wonderful evening to the speakers, to our sponsors, PENTAX. I hope it's been thought-provoking, and enjoy the rest of your evening. Thank you.